So the first thing that we are going to start is basically antenatal counseling. So basically, how you are going to start. So first, before birth, what are you going to tell the patient? That is very important. So don't forget that you are going to start not from just the birth, but from the counseling. So you have to start from the counseling, put all the equipments, all the ops, gynae, whoever is needed should be in the place, all the anesthesiologist, whoever is needed should be in the place. And then starting from the counseling, then moving on to the next step would be birth. Don't forget that antenatal resuscitation doesn't start from birth, but start from counseling. You have to tell the patient the whole, like all those 9 months and everything, what you do. And then before the birth, what are you going to tell the patient? What are all the preparations you need to do? And then comes the birth. Now comes what are after the birth, what are you going to do? Is basically term gestation, good tone. So all of those EPCAR scores, so you are going to do. And on the basis of that, you are going to see if this patient needs further assessment or not. So if the patient needs further assessment, what are we going to do is we have to see what kind of assessment is needed. Is it the circulation problem? Is it the breathing problem? Or is it the position or airway is because you are not cleaning the airway properly? So from there, you are going to move on. So first comes is basically if tone, gestation, breathing, crying, everything is good, then what are we going to do? Infant stays with the mother for routine care, warm and maintain normal temperature. So if somebody is coming with a good EPGAR score, what are you going to do? So this is what you have to write down. In the CDM, in the MCQs, if they give you, so you have to write down these multiple steps. What is that? Warm and maintain normal temperature, position airway, clear secretion if needed, and dry ongoing evaluation. So this is for the normal EPGAR score, more like 9 or above that. So then coming, if that EPGAR score is unlikely in the normal range. Now, what are we going to do? We have to start with the normal warm temperature, putting the baby close to the mother, or if needed, we have to clean the airway secretions, and if needed, we have to dry and stimulate the baby. Maybe baby is sleeping, that's why it's not giving the proper EPGAR score. So baby needs to cry, and then breathing and all of this going to start. So now from here, we are going to assess if the patient is having, not patient, actually baby is going to have apnea or gasping, or heart rate is below 100. Now this is kind of problem. So if this comes, apnea and gasping is not happening, then it's okay. It is like a labored breathing, maybe persistent cyanosis. You will eventually put some positive pressure ventilation, give a little bit of oxygen, and baby will recover. But if the baby is having apnea along with heart rate below 100, this heart rate below 100 is very important. Apnea can be present, but later on if you give oxygen, maybe it could recover. But having heart rate below 100 is kind of dangerous. So what are you going to do? Obviously starting with positive pressure ventilation, oxygen monitor, because you need to do see if the oxygen is level is normal, or is just the normal cyanosis, or is the oxygen is not going properly. So you have to rule out RDS, transient tachypnea of neonate, all of those conditions. Then comes to the ECG monitor. So maybe any inborn error of congenital heart disease is happening, like VST, AST, teratology of Fallot. So all of this, what are you going to do is basically ECG. Then coming back, if we see on all of these that heart rate is still below 100, now what are we going to do? If it's not, then obviously postnatal resuscitation care, debriefing, you have to tell the patient about what happened, we try to recover it, give oxygen, all this CPP, and then baby is going to be in the normal state. Now, but still, if the everything is done and heart rate is still below 100, what are you going to do? Check chest compression, chest movement, if the baby is breathing properly, or there is something that is stuck in the throat, maybe that is not causing the proper airway inside and outside. So ventilation corrective steps if needed. Then what are you going to do is basically passing ETT tube, maybe having tracheoesophageal fistula, any atresia is happening inside the trachea. So all of these are things that are going to be ruled out, and then after that you are going to pass the ETT. Then after doing all of this, still heart rate is below 60. After this, now you are going to start the chest compression. Remember, below 100, you are not going to do chest compression. Below 60, you are going to do chest compression. Then coordinate with PPP, oxygen, ECG, monitor. So everything is going along with it. We can add only chest compression below 60. So it is very important, after 100, what are you going to do? Below 60, what are you going to do? And if 60 is keep on repeating like that, then you are going to add epinephrine. It is quite different in adults, and it's quite different here. So you need to know proper where you are going to add chest compression after 60. Okay, so this is the whole resuscitation table. It's very nice, and you can do it from here. If you want to read it from Toronto notes, if you will eventually find out the same stuff in Toronto notes as well. Okay, so now I'm going to add just a second. So now we are going to start. Just a second, somebody is trying to add it. Okay, so now we are going to start from basically pediatrics. So let me just open up pediatrics real quick. Okay, so pediatrics is basically already we did neonatal resuscitation. So you can read it from here. It's very nicely written here. All of these topics are important, especially the neonatal resuscitation. A lot of MCQs, a lot of maybe sometimes they give a CDM. So you have to properly write if that particular condition, what are you going to do? So now we are starting from the mass, Wilms tumor. Wilms tumor is one of the very, very common complication that can present in family physician, having a mass in the abdomen. Mother was giving a shower to a baby, and then she finds a mass in the belly of the abdomen, so belly of the baby. So now she's coming to you and now asking what is going on here. So usually diagnosed at 2 to 5 years, male and female normal. So most common is basically renal neoplasm. And then differential diagnosis, you need to know what could be the cause of that particular mass in that particular area. So regarding all the conditions with the kidney, like hydronephrosis, polycystic kidney disease, renal cell carcinoma. So if you linked with the nephroblastoma with the different conditions, which is linked to the kidney, it will help you to build up a diagnosis. Then clinical is basically mostly asymptomatic. That's why the mother noticed it and bring the baby, because it is asymptomatic, unilateral abdominal mass. Then maybe present with the hypertension, gross hematuria. It's very unlikely that the baby will present like that, but it can present with hypertension, gross hematuria, abdominal pain, vomiting, fever, UTI, anemia. So you need to keep all of these clinical features in the back of your head if it's coming. So you have to rule out Wilms tumor in 2 to 5 year old. Then it is linked with the Weger syndrome. It is very important. It's not written anywhere how you are going to do further, but you need to know at least which disease is linked with which congenital syndrome. It could be asked in MCQs. So at least know this Weger syndrome, then those D George, catch 22, those things. So you need to know what kind of conditions are linked with these particular condition. So Wilms tumor, aniridia, genitourinary, and mental retardation. Then back with Weidman syndrome, if you can read it, it's good. If not, then at least know a little bit of features like enlargement of the organs. So it is like how I remember is basically it's wide, so everything is enlarged. Okay, hemi hypertrophy, so organs are enlarged, cyst and adrenal cystomegaly. Then management, as we already know, we are going to just do the diagnosis. The management is going to be done by some specialist, but at least we need to know what that specialist is going to do at nephrectomy, right? So that is thing. Then chemotherapy, radiations for the higher stages. Prognosis 90% they survive. Investigations, if they ask you in the Wilms tumor, what kind of investigations you are going to do? If she, the baby is coming with a hematuria, you have to rule out other causes of hematuria like post-streptocccal glomerulonephritis or having any tumor. So you have to rule out all of these conditions which can present with hematuria. You cannot just label because hematuria is coming, so it's Wilms tumor. You have to, it's kind of diagnosis of exclusion kind of thing. So then on the basis of that, you are going to do ultrasound just to confirm your diagnosis, then contrast enhanced CT or MRI, chest, abdomen, and pelvis. So you have to do all the CT scan of the abdomen, but it is very unlikely you do CT scan in the pediatrics. But wherever it is needed, you have to write down. Okay. Then comes the neuroblastoma, most common cancer occurring in the first year of the life, neuroblast cells, tumor arising from the sympathetic tissues. Then clinical features, it can present with a thoracic, abdomen, paravertebral, any of these. So at least know these features, so it will help you to make a diagnosis. This kind of a question can come in MCQ, so you need to know this. Then paraneoplastic, it can present with hypertension, palpitation, sweating, and opsomyoclonus, and diarrhea and FTT. Management is basically finding out the prognostic factors, how likely the baby will have good outcomes in the life and how unlikely the baby will survive. So all of these are going to be play a big role in the management. And that is not particularly done by us. It's going to be done by an oncologist. Just know if they ask in the management, you are writing history, physical examination, then investigation. And in the management, you need to know what at least 1 or 2 words you are going to write. Just at least touch it, okay? Then prognosis, basically good prognostic factor is written here, age, stage, you need to know. Then investigations, what are your investigations? It could present with hematuria or diarrhea or dyspnea, so you have to rule out all those problems which can present with that way. Maybe like having pheochromocytoma, right? So it can present the same way, so you have to rule out catecholamines, MRI, CT, biopsy. Then definitive diagnosis need one of the following, like having tumor tissue and aspirate biopsy. If they ask for definitive diagnosis, you are not going to write MRI, CT, MEBIG scan, right? Here, the diagnosis is basically done on the histology diagnosis, so like having a biopsy, okay? So that is important. Just give it a read. Wilms tumor is more important than neuroblastoma, but I won't say just because Wilms tumor you are doing, miss neuroblastoma, okay? Now moving on to the next one is basically otitis media. Okay, I know otitis media, you can do it by yourself. There is few things that I want to highlight here. When you are writing CDM, what you cannot miss when touching or solving the otitis media. First of all, you need to know at least you are writing a full diagnosis. Just writing acute otitis media is not enough. You have to know acute otitis media with effusion and without effusion. Okay, if there is no effusion, then you can just write acute otitis media. But with effusion, sometimes they mention that there is something coming out from the ear, so you have to mention that this is coming out and this is an effusion. So what are the etiology? Like all this Streptococcus pneumoniae and anaerobes and the viral can cause. Then risk factors you can read, having an obstruction like those cleft palate, Down syndrome. As I already mentioned, there is a lot of syndromes that is present in different kind of diseases. So at least know these syndromes, so it will help you in a lot when you are writing, just writing Down syndrome and you couldn't come up with any word. So at least if you read it from somewhere other disease, you can write down and link up a little bit of it. So it will help you to write down. And when you are sitting in an exam, something unrelated come from that particular syndrome, you know at least 1 or 2 words that will help you. So sometimes it happens. It's not like it's 100% that is going to come, but sometimes, hard luck. So at least know a bit about it, so you can easily write at least 1 or 2 words, okay? Then comes the cartilaginous syndrome, cystic fibrosis, genetic predisposition, behavioral. So it can present with behavioral and environmental exposure. So all of these can be like having feeding problem, daycare, sick. Don't forget the common ones just because you are doing the uncommon ones, okay? So having this lifestyle modification is one of the very important thing. So like basically this maybe the parents are not taking care of properly, so bottle feeding, laying down, pacifiers, hand. So these ones are important. Then you can think of Down syndrome. Just because you are thinking Down syndrome and you are not thinking maybe the baby is having a bottle feeding problem, right? So you need to know at least what things you can ask in history and exclude them, instead of just going directly jumping into some very weird syndrome like having Cartagena syndrome. It's kind of like unusual that a family physician will see a patient in their whole life a Cartagena syndrome, but seeing a lot of patients with a bottle feeding lying down will be a lot, okay? So no commons and then uncommon. Just don't miss uncommon as well. Then coming the immunosuppression deficiency, chemotherapy, diabetes mellitus, hypogamma globulin, and then pathogenesis, you can read it. It's just pathogenesis just for your idea, okay? Then this is the very nicely management written here on the basis of recommendation, how you are going to assess it. So clinical features, you can read how this is going to present. So very nice table here. This is what I want to discuss. This is the management more than 6 months. So you need to know, you are not going to write down middle ear effusion with, so you need to know acute otitis media with middle ear effusion. So at least you know with effusion and without effusion. It is very important, or even perforated one. Just writing acute otitis media is not going to complete your whole question or not going to give you a full mark. As we already read in CDM question, if you write down thyroid disease, it's not going to give you good marks. You have to write full marks or R mark, okay? So you have to write down hyperthyroidism. They particularly want you to know from that particular diagnosis, from that particular clinical features, which particular diagnosis they are talking about, okay? Just writing down middle ear infection, it could be anything, right? So you need to know acute, which one is it? So on the basis of all these features, you will be easily differentiate which one is this. So here I want to see, this is the management. Symptomatic is basically starting from antipyretic, analgesics, watchful waiting, antibiotic, less than 6 months. This is what I want to highlight. It is very important. Then in less than 6 months, with moderate or severe illness in any age, what are you going to give? High dose insulin. Insulin, I'm saying high dose amoxicillin. Just writing amoxicillin is not enough. Okay, just writing amoxicillin is not enough. You have to write down high dose amoxicillin. This is the full answer when you are writing CDM question. So when you are writing CDM question, just writing amoxicillin is not enough. I know you don't need to remember doses, you don't need to remember route, but here high dose is important because it is moderate and severe, and they are giving you particularly hint that this is already moderate, this is already severe, this is already, the baby is less than 6 months. Okay, so I have seen a couple of questions in ASQ bank where they were mentioned asking you to write down high dose amoxicillin. Then coming the second line is basically amoxicillin plus clavulanic acid, cephalosporin. So you can write all of these. This comes the second line. Then signs of the perforated one. See, I told you they have given you the signs of perforated tympanic membrane. Then you have to write down which kind of diagnosis and which kind of treatment you are going to write. So if they give you a signs of perforatic one, then you are going to give antimicrobial therapy and examine for the complications. Prevention is needed. How you are going to do, because he is having a lot of infections. So you have to give pneumococcal influenza vaccination along with the surgery. Maybe he needs surgery, having a lot of effusion is going on. So you need to give surgery, and choice of surgery for the recurrent on the basis of the local factors like speech and tube and dysfunction and responsible use. So you need to know when you are going to put the tubes, at which stage you are going to put the tubes. So it's needed. Then complication, it could cause, obviously the infection could be spread to the brain, to the underlying all the tissues. And what happened in the children's, particularly they will have a hearing loss or speech delay. That's why whoever is having speech delay, they can present in the underlying feature of acute otitis media. So somebody who's coming with a speech delay, you have to rule out acute otitis media or multiple infection. So these are one of the very few things you need to know what could be linked with what particular disease. Maybe that particular thing could be told and you are supposed to diagnose it on the basis of that. So that's why you need to know speech delay could be one of the presentation of the middle ear effusion. So what are you going to rule out is middle ear infection. Then comes the tympanic membrane perforation extension, and then cholesteatoma, facial nerve palsy, and intracranial would be any meningitis, abscess, epidural empyema, and cavernous sinus thrombosis and carotid artery thrombosis. Then all of these things are written as already like more than 6 months. As I already said, this is less than 6 months. You are not going to see this is a middle ear effusion or not effusion whatsoever. If it's a middle ear infection and the baby is less than 6 months, you are going to give high dose amoxicillin. But these all features are going to apply on the baby who is more than 6 months. Okay, so it is important you know which age you are going to do what. Generally healthy acute otitis media illness or acute illness with or without fever, ear dysfunctions, and suspect. To see which one is it. Is it middle ear effusion or is it middle ear not? It's not. Okay, so now we have to see without middle ear effusion present, and perforated tympanic membrane. So now coming to this one, you find out that this is without middle ear effusion or with the middle ear effusion but non-bulging. It is quite normal or mild one. You can say having a little bit tympanic membrane is red. You see it on otoscopy. Now what are you going to see? Maybe it is viral. All you have to do is reassure it for at least 24 to 48 hours. So this is important. You need to know at how much you can reassure and ask her to come back again. So you are going to ask her to come back in 1 or 2 days, if not clinically improved. And after that, you are going to start the treatment. If there is a perforation, you are going to start the treatment right away for the 10 days. But middle ear effusion, it comes with the two, bulging. It is mildly ill or moderately ill. It comes with the bulging. Now it is further divided into two, like mildly or moderately. Mildly maybe having like alert, he's totally okay, having a little bit of fever, and the infection is not more than 2 days, like having less than 48 hours, and the fever is not too high. So everything could be okay. So you can either reassure if the parents is okay with the reassurance, you can say that if the parents are okay with assurance, so you can advise her to come back. If it's not resolved, take Tylenol for the meanwhile. If not clinical result, you can come back. But at the same time, if they said no, we want treatment, you can consider the treatment as well. Okay. Then coming the moderately or severely ill, then irritable, sleeping, poor responses, antipyretics. Since now it has been past that mild stage, like having more than 39-degree fever, having more than 48 hours, 48 hours, then treat with antimicrobial and 6 to 2 years of the age for the 5 days. So this is for the 10 days and this is for the 5 years. Okay, now at otitis media with effusion is just the same. You can read it. All of the things are written here. How you are going to document for the hearing loss is important. If you are treating this, you have to check for the hearing loss. So writing down just the treatment of the otitis media with effusion is not enough. You have to document for the hearing loss as well. Sometimes they want you to rule out any complication. So you need to know at which stage you are going to rule out the complication. Since it is written in treatment, so documented hearing loss is the part of treatment. No statistically proved with antihistamine, so these all are not needed. So you can do laryngotomy, tympanostomy, tube. So complications is also, first one is hearing loss, then speech delay. So it can present with a speech delay. So it is important. Then coming to the infectious pediatric xanthems, is basically fifth disease, having those red cheeks, babies coming to you. So you need to know which virus is coming. I couldn't remember this incubation period. If you are good with memory, go for it. I couldn't remember it, so you can read it. Then respiratory infection, secretion, then rash. How can it present with the slap cheek? All of these presentation you need to know, and then associated with 7 to 10. What are you going to do is sportive treatment. So most of them, they are going to show you a picture of the slap cheek, and then they are going to ask you which organism is this, or which organism was the cause, or what is this disease, or how you are going to treat this patient, right? So you need to know on the basis of that picture, this is fifth disease. Now how I'm going to treat is basically sportive. If that particular mother is coming with it, so what I'm going to do is basically ask them to stay away because it could spread from the respiratory infection, secretion. Asking about the particularly pregnant woman. A pregnant woman is working in a daycare, having exposure to the slap cheek. What are you going to do? So those things are important as well. And I think it's written in infectious diseases chapter. So you need to know, especially the measles, mumps, rubella. Then comes the Giannosti, Crosti syndrome. Okay. Then hand, foot, and mouth disease is basically Coxsackie virus. Then these things you can remember it if you want. Then direct and indirect contact with the infected bodily, fecal, oral. Then appearance, you need to know how does it look like. The baby will have what, they will tell you that the baby had the disease at the hand, foot, and now he's having a problem in the mouth. So what are you going to do? So you need to know this is hand, foot, and mouth disease. The treatment is basically sportive and resolves in 1 week. And what are you going to counsel about? Dehydration. Then comes the herpes simplex. It is a very painful one. So direct contact can cause it. Then grouped vesicles on the erythematous. So it is different from the hand, foot is basically anterior, and this is basically posterior. Okay. So you need to know a little bit about it because this is already very painful and this one is not that painful. So you get to know with the pain that is herpes simplex and with that is not one. So what are you going to do is basically sporty, but having too much pain, what are you going to do is antiviral. So all of these are complications that could happen. Kawasaki is written in the end of the chapter and we will read it. Then measles, you need to know which organism, how this is going to present. So you need to take out the pictures from the Google and see it from there when you are reading it. What kind of important thing that it can tell you? Coplic spots. So you need to know how does those coplic spots look like. What are you going to tell is basically sportive. Along with it, what are you going to do is vitamin A. And these all diseases or these all viral infection which have immunization is supposed to be reported by public health. Mark my words, whichever has immunization and is not particularly immunized, that particular baby, or even he's immunized and he's now having measles, what are you going to do is public health prevention for the MMRV vaccination. So all these infections. Then coming to the roseola, then HHV. Then this is basically droplet infection, comes from the saliva. Appearance, how does it look like? So you need to know, take out the picture because most of the time they give you this thing, but seeing a picture will help you to build a diagnosis more nicely. Then how does it present? Like what are you going to do? So all the viral infection, you don't give anything, just give sportive treatment. Then rubella. Rubella is basically caused by which organism? How they are going to spread? How does it look like? And what are you going to do is basically having, because this has immunization, so you are going to report to the public health. Then outcomes, and then scarlet fever is nice, so it will return downward, we will see that. Then varicella, you need to know how does it look like, which organism is causing it, and how you're going to treat it. So one of the very important thing that I want to highlight here, just because it's written here, avoid salicylate. Only one condition you are going to give salicylate is Kawasaki. Otherwise, in the children's, you avoid salicylate because of the Rey syndrome. So they can tell you that he was given a salicylate. Now what could be the complication, or you need to know at least this one, and which one disease you can give salicylate easily. Okay, so what are these are, so this is also public health one. So public uh, public health prevention. Infection mononucleosis, you need to know how infection mononucleosis is different from the streptococcal pharyngitis. Streptococcal pharyngitis is kind of different from this one. It has splenomegaly, it has the anterior cervical lymph nodes are involved. Those ones has posterior cervical lymph nodes are involved. So little bit of features will help you to build the best diagnosis. And on this one, you are going to always counsel about not to play. Okay, splenic enlargement, that is you're going to avoid contact, and for how long you are going to ask the patient to avoid contact, 6 to 8 weeks. Knowing this is very important. Don't miss just because you are writing avoid port contact is not enough. You have to write down 6 to 8 weeks. Okay, then you need to know which organism is causing it, then how does it present, like what are history questions you are going to ask. Physical examination is classic triad, hepatosplenomegaly, periorbital edema, rash, petechiae. So all of these can present. Along with it, itis, all of the infection, anything could happen from it. So all the infection, arthritis, hepatitis, nephritis, meningitis, encephalitis, anything could happen. What are the tests you are going to do is heterophil antibody test. So unlikely you go from CBC, differential blood smear. You have to start, if you are suspicious of infection mononucleosis, you can start with the heterophil antibody test. But if you are not, you have to do the test to rule out streptococcal pharyngitis. That's what I said. If streptococcal pharyngitis, you are going to do throat culture. If this one, you have to do heterophil antibody testing. Then management is mostly sportive. You don't have to give anything else. Airway obstruction, what are you going to do for the tonsillar enlargement? Prognosis is good. Then infectious pharyngitis, this would be the last topic we will cover. So infectious pharyngitis and tonsillitis, you need to know which organism. Mostly is viral, so it will resolve by itself. So GAS can present sore throat and everything. These are everything are written here. So pharyngeal tonsillar edema, this strawberry tongue, scarlentiform rash, and then viral. It could present like that way. Then what are the investigations you are going to do? The important investigation which you are going to do is basis on the M-Centaur score. It is important you know which M-Centaur score. I think it's not written here. It's written in the family medicine. So you can read it, which one is the M-Centaur score. It's, I think, here. So M-Centaur score is basically Streptococcus pharyngitis for the patient presenting with the sore throat, pharyngitis, and upper respiratory tract infection. So you have to put all of the features that is given in the scenario into this one, and on the basis of that, you need to see what I'm going to do next. So must be more than 3 years, cough, no cough, then plus 1 point, exudate or swelling. Sometimes you feel like pharyngitis can present with a cough. It's not important. Streptococcal pharyngitis does not present with the cough. Exudate or swelling, tonsillar exudate, plus 1. Then nodes, anterior. This one I was mentioning. Anterior is common in the streptococcal, and posterior is in the in that one. So temperature, history of the fever, and only young patient less than 15, and early, if more than 45, so it will be -1. So on the best of that, if it comes as 1, there is no need to do any further investigation. But if it comes at 2 and 3, you are going to consider rapid streptococcal testing. And then if it's more than 4, you are going to consider either rapid streptococcal testing or culture. And then empiric treatment will also be starting at the same time. Okay. So now this is the management, same written here. What are the antibiotics you are going to give is basically penicillin, along with its sportive treatment, follow-up, and prophylaxis. Then you need to know the prevention. What are, if you are going to give antibiotics, which diseases you are preventing from. And immune-mediated scarlet fever, acute rheumatic fever. So these are the complications of this one. So these ones are written here. Scarlet fever, sore throat, strawberry tongue. Okay. And scarlet fever had sandpaper like rash. So take out the picture from Google when reading it. So you need to know. I have seen one picture in some Q bank where they were showing us just the picture, and a baby is coming to you having a sore throat. What is it? It's basically scarlet fever. So knowing how does this sandpaper like rash looks like, it's important. Okay. So what are you going to do is basically penicillin and amoxicillin. Then rheumatic fever, it is basically inflammatory disease, and clinical features. You need to know that John's criteria. So on the basis of that, you are going to start with the treatment, which is basically penicillin, and secondary prophylaxis with the daily penicillin. So you need to know which when I'm going to give the prophylaxis. Then complications, myocarditis, conductal infection. So all of these infection can spread all the way. Then post-streptococcal glomerulonephritis, most commonly in the children's age 4 to 8 years, and male more than female. And then antigen antibody mediated complement, GAS forms, clinical features, asymptomatic, microscopic and macroscopic, diagnostic. So management is basically symptomatic. So here the management is different from that one. So you need to know where this presentation is coming. You are not going to put the patient on the penicillin. You can, but on the same time, the first treatment would be fluid and sodium restriction. So the diagnosis is changed, the treatment is changed. Okay. Then loop diuretic for the HTN and the edema. So first thing first, if they're asking for the first initial, then fluid and sodium restriction. And if they ask you what like antibiotic, what medication you are going to add, so it would be loop diuretic if they're giving you a presentation of hypertension. In severe cases, what are you going to do is dialysis and treat with the penicillin and erythromycin. So that's it for today. And I hope you guys read this topic. These are very, very important. Pediatrics is one of the very favorite topic of the exam.